Hi, I'm Rochelle McIntosh from WANADA, the West Australian Network for Alcohol and Other Drug Agencies. It's with appreciation that I welcome you to join us in supporting the global goal of elimination of hepatitis C by 2030. But firstly, I'd like to acknowledge that WANADA is based on Whadjuk Noongar land. We acknowledge the Aboriginal and Torres Strait Islander people as the traditional custodians of this country and its waters. And we pay our respect to elders past and present, and we extend this to all Aboriginal and Torres Strait Islander people from the lands on which you are based. As you may know, we've come a long way in hepatitis C treatment over the last decade. However, people who inject drugs continue to remain at the greatest risk from hepatitis C in Australia. By supporting people who inject drugs to access testing, treatment and support, we can reduce Hep C transmission. Alcohol and other drug treatment services play a key role in improving access, engagement and continuity of hepatitis C care, and evidence shows us that when these services are well equipped, we can make a real difference. WANADA's been working alongside alcohol and other drug services in Western Australia to strengthen Hep C care at a service, organisation and sector level. One way we've done this is through the Hep C Care Capability Project, a capability building approach that started in 2019 and has evolved through ongoing collaboration and support from WA Alcohol and Other Drug Services. This video was developed as part of the project and funded by the WA Department of Health. In this video, you'll hear from 3 people with deep knowledge and experience of alcohol and other drugs, our service sector and service users, and hepatitis C. Matthew Armstrong from Hepatitis WA will take us through key facts, where we started, where we're at now, and why we can't afford to lose momentum. He'll also share the supports Hepatitis WA provides to support people affected by Hep C. Then we'll hear from Peter Garver at Peer-Based Harm Reduction WA, who brings the consumer perspective. What makes engagement work and what services can do better? You'll also hear how Peter and Peer-Based Harm Reduction WA can support alcohol and other drug workers in providing harm reduction and hepatitis C care. Finally, you'll be introduced to Tabitha McCallum, a project partner with extensive knowledge of alcohol and other drug services in Western Australia, and a capability coach and service auditor who's supported services to build their capability over many years. Tab will introduce you to the Hep C capability tool, the Hepatitis C virus care capability in alcohol and other drug treatment tool, or otherwise known as the HCV CAT. WANADA has been working with TAB and the WA Alcohol and Other Drug Services and Service Sector to develop and refine the tool to support services to assess and develop their Hep C care capability. TAB was involved in the early design and implementation of the tool and helped shape the latest self-review version, drawing on insights generously shared by WA Alcohol and Other Drug Services to the benefit of the sector. Every conversation, every action and every system we strengthen brings us closer to eliminating hepatitis C. This video was developed to support that work here in Western Australia. So let's get into it.
Hello, my name is Matthew and I'm the Acting CEO at Hepatitis WA. Today I want to talk about something huge, the elimination of hepatitis C in Australia by 2030. That's right, a viral disease, no longer a public health threat. This is rare in public health, and with the arrival of effective Hep C treatments in 2016, we now have the tools to make it happen. But we need a final push, and the alcohol and other drug workforce is crucial in that effort. Hepatitis WA is a government-funded non-profit. Our mission to improve the health and well-being of people affected by viral hepatitis. We provide education, support, primary prevention through our NSP, and even primary health care through the Dean Clinic, our bulk billing GP service specialising in STI BBV screening, treatment and management. Rapid results, walk-ins welcome, no judgment, just healthcare. At its highest, there was up to 230,000 Australians living with Hep C. Now, there are still about 75,000. Treatment has had a tremendously positive impact on Hep C rates in Australia, and in some ways, we are leading the way in our pursuit of elimination. Historically, new infections in Australia climb by 10,000 a year. That's about one every hour. We're making progress, but we're not there yet. While 70 to 80% of cases are diagnosed, many people don't seek treatment. Why? Stigma, misinformation, fear of discrimination, poor experiences in healthcare settings, or just sheer survival, especially for people dealing with homelessness or incarceration. Treatment today is simple. No chemo-like side effects, no waiting in line at specialists, just a few pills for a few months. Yet many people don't know this. Some had terrible experiences with the healthcare system and don't want to go back. Others think treatment is expensive. It's not. That they need a specialist. They usually don't. Or they only get one shot at it, which is false. For some, hepatitis C isn't even on their radar. When you're worried about where you'll sleep tonight, a virus that you don't feel yet isn't a priority. And in prisons, the cycle of reinfection is relentless. Hepatitis C spreads exclusively through blood-to-blood contact. Sharing injecting equipment is the biggest risk. Syringes are incredibly efficient at transferring microscopic blood particles, even ones too small to see. The virus can survive outside the body for weeks, making used equipment a major risk. When Australian NSPs were introduced in 1985, they were designed to slow the spread of HIV, but hepatitis C was already silently spreading. By the time we even named the virus in 1990, methadone clinics had 95% infection rates. We've been playing catch-up ever since. NSPs prevent 10,000 infections each year. Without them, we'd double that annual 10,000 case increase. You could say, in modern times, the problem of hepatitis C isn't double thanks to NSPs. But we were containing, not eliminating. The final step is treatment. Prisons are hepatitis C factories. 60% of people in prison have a history of injecting drugs. At least 25% continue to inject inside, and of that group, 95% will share. There is zero legal access to sterile injecting equipment in Australian prisons. Needles are smuggled in, sharpened on concrete, and passed between multiple people in secret, sometimes 100+ people in a week. Many prisoners see hepatitis C as inevitable, just Hep C. Sometimes people now take risks because they know they can be treated later. But that means another cycle of transmission. The good news, since 2016, prison rates have dropped dramatically, with most facilities now reporting 10 to 20% prevalence. But only half of inmates even accept a test, so we don't have the full picture. The solution? Treatment and harm reduction together. We've moved from year-long, grueling interferon treatments to simple, effective, and curative medications. They work on all strains. They're 95% effective, minimal side effects, available through GPs and nurse practitioners, dispensable at pharmacies, and free on Close the Gap or low cost on concession. Remember, elimination means 90% fewer new cases, 90% of people diagnosed, 85% of people cured, and 65% fewer deaths from liver disease. We have the tools. Now we need the strategy. The role of AOD workers and how you can help. Normalise the conversation. People test when they realise they're at risk, not when symptoms appear. Making the discussion of risk-taking behaviour part of routine can assist people in reflecting on their level of risk accurately. Brief interventions work. Take every opportunity to mention testing and treatment. Get visuals, posters, flyers, anything that keeps the message visible. Hepatitis WA can help. Train your team. Our free training makes sure your workforce is ready to support clients. Know your referral pathways. If someone wants help with testing and treatment, where do they go? If you don't have a dedicated referral agency, use the Dean Clinic. Hepatitis C elimination is within reach, but it won't happen on its own. The easy to reach people have been treated. The ones left need engagement, trust, and opportunity. The last piece of the puzzle, awareness and action. We need to make noise, spread the message, and push forward. Together, we can eliminate hepatitis C in Australia. Let's get it done.
Hi everyone, my name's Peter Garver and I work at Peer-Based Harm Reduction WA, and I'm here today to talk to you about hepatitis C in the AOD community in Western Australia. So you don't have to be a health professional to help eliminate hepatitis C in Western Australia. We all want better outcomes for the people that we're working with, and we already have the tools to make that possible. So what's stopping us? People talk about priority populations being hard to reach, and it just isn't true. A one-size-fits-all approach is not enough when we already know that there are significant barriers that prevent people from coming to us for testing and treatment. We need to understand the unique needs of the people we are working with and then find ways to bridge those gaps so we can take testing and treatment to the consumer. But to do this, we have to work together. By committing to continuous engagement with consumers, choosing referral pathways that offer consumers options that meet their needs, and by being able to share simple but accurate information, we can all help change lives. For years, we've been hearing the phrase "find the missing millions" when we talk about the elimination of hepatitis C, and I find it quite misleading. It oversimplifies the issue. Lasting elimination is about more than a simple search. It requires strategies, including the identification of risk factors and barriers, targeted testing, and stigma reduction. It puts an emphasis on quantity over quality, which can overshadow the importance of providing appropriate care and follow-up. Lastly, that phrase suggests that there is a fixed number of people with hepatitis C. However, the population of people living with hep C is dynamic. There are new infections, reinfections, and people clearing the virus every day. So instead, let's talk about some of the hepatitis C red flags we can listen out for when we're engaging with the people that we work with. So, people who do not access health services. It's really easy to forget sometimes that people may only be accessing one service, and that service may not be a health service. And so, anytime we're working with people that may not be in touch with health services, that should be a red flag to us. There are people who are living with hepatitis C who already access AOD services, people who inject drugs or have injected drugs, people who have been incarcerated, First Nations people, people who are partially diagnosed with HCV and are lost to follow-up, people who are hesitant, doubtful, uncertain or unaware of treatment, and also hepatitis C amongst people who are psychiatrically unwell. So common misconception there that if people are receiving care, psychiatrists are not always treating hepatitis C. So we've all had bad experiences, and it can be really hard for us to engage with health services openly, honestly, or at all. Past experiences of discrimination and judgment from healthcare providers or other authority figures can create deep-rooted mistrust amongst people who inject drugs. This makes it difficult to establish rapport and open communication. To cope with these past negative experiences, people who inject drugs may develop defensive or resistant behaviours, and this can make it challenging to engage in open and honest conversations about hepatitis C. Individuals may blame external factors for their Hep C infection or deny its severity, making it difficult to motivate them. Past experiences of power imbalances can lead to feelings of intimidation, making it difficult for people who inject drugs to participate fully in conversations. To overcome these challenges, it's essential to build trust and to create a supportive environment which can take a consistent effort over time. It's really important that we avoid medical jargon and use plain language that is easy to understand. So I guess it's important to remember when you're engaging with people who inject drugs that it's not just about what you say and do. Almost all of us have had bad experiences with healthcare in relation to our drug use in the past. And whether you realise it or not, this will affect the way that you engage with us. Stigma changes the way that people who inject drugs see themselves and the world around them. Previous experiences of inequitable treatment and judgmental attitudes can actively deter people from seeking care and will affect their ability and willingness to engage with you. We need support to return to healthcare services and become advocates for ourselves. And so, we talk about eliminating Hep C and we think about getting people through the door for treatment. But, it's not always a one and done approach. I think we need to be mindful that if we really want to eliminate hepatitis C, we need to welcome people back to healthcare services. And so by doing that, people will become advocates for themselves and be able to prioritise their own health into the future. So the term hard to reach is often used to describe individuals who are difficult to engage in healthcare services, including those with hepatitis C. While it might seem like a straightforward descriptor, it carries several implications that can be misleading and counterproductive. Firstly, it implies that the problem lies with the individual and their personal circumstances, rather than with the healthcare system failures or societal barriers that are affecting them. This term can inadvertently reinforce negative stereotypes about people who are living with Hep C, suggesting that they are somehow inaccessible or undesirable. It fails to acknowledge the multiple and interconnected factors that contribute to individuals disengaging from healthcare, such as poverty, homelessness, trauma and mental health issues, discrimination, and lack of trust in healthcare providers. Most of all, focusing on individuals as hard to reach can divert attention from addressing systemic issues that prevent people from accessing care. By shifting the focus from individual shortcomings to systemic challenges, we can develop more effective and equitable approaches to Hep C prevention, care and treatment. If we get better at working together, we can reach people. And so, some of the barriers that people face and some of the ways that we can address those barriers are by recognising that for some people, competing priorities and logistical challenges can make engagement really difficult. So I guess we have to remember that we're asking somebody to prioritise a condition for which they may not even be noticing any symptoms. If I'm worried about housing security, food security, financial hardship, if I'm struggling with physical dependence on a substance, all of those things can make my priorities change from day to day, and hepatitis C may not really be high on that list, and so I'm going to need some help to prioritise it. Mental health and lifestyle challenges, stigma and fear of judgment, and also a lack of awareness. Just because these new treatments are available and they're highly effective, it doesn't mean that everybody has all of the information. Interferon horror stories are still a really common barrier that prevents people from coming forward for treatment. And so I guess a more beneficial approach to working with people who are experiencing these challenges would be to offer them services where they live or where they are already accessing another service. So if we can provide referrals with options that meet that person's needs, we make it easier for that person to prioritise Hep C. By referring people to services that provide peer support and case management, This can help people to complete treatment successfully. We need to make services free of charge. And if your organisation cannot provide these options, then you can work in partnership with an organisation that can, like Peer-Based Harm Reduction. Who are Peer-Based Harm Reduction WA? Well, we provide health and harm reduction services aimed at reducing the prevalence of bloodborne viruses and STIs, preventing overdose deaths, reducing the incidence and severity of other harm which may be associated with drug use among the community in WA. We're a low threshold service with a reputation for doing that well. And so what that means is, with all of the services that we provide, we like to say, if you can't come to us, then we'll come to you. And so we provide many of our services in an outreach capacity. For example, our needle and syringe exchange program, we have fixed sites here in Perth and one in Bunbury servicing the Greater Southwest area. But if you can't come to us, we can provide that service through outreach delivery to your home, or even through a statewide postal service. And the same can be said for our take-home naloxone program and even our health clinical services. But one thing that really sets us apart from other services is that we are run by and for people who inject drugs, and that makes us the consumer voice in WA. Our clinics are overseen by an experienced hepatology nurse practitioner who is able to prescribe treatment for hepatitis C. We provide free testing and treatment for bloodborne viruses and STIs, as well as vaccinations and general health care. We are a one-stop shop for Hep C testing and treatment. So that means that all of the services a person will require in order to complete treatment successfully, they can be accessed here at Peer-Based Harm Reduction without having to go anywhere else. We have hepatitis C case management workers who are peer workers and are trained to provide testing and greatly increase the level of support that we're able to provide. And so anyone who comes to see us for treatment will have their own individual and unique needs. Some people need higher levels of support, and that might look like weekly check-ins to help people to remember to take their medication. People may have other co-occurring appointments for psychosocial issues, other health issues, and they may require support to attend those appointments. And our case management workers are able to provide that. You may not be aware that filling a prescription for hepatitis C treatment medication is not always straightforward. While these medications are available on the PBS, a lot of pharmacies don't actually keep those in stock. And if the length of treatment is 3 months, that means that there are 3 scripts that will need to be filled. And so a person will need to phone ahead and let their pharmacy know that they're going to run out in a week's time and they'll need to order that medication in for them. Our case management workers can simplify that process by filling those prescriptions and actually dropping the medication off to people wherever is convenient for them. And we have had people access us who are street-based and unable to carry a month's worth of medication with them. They either lose it, it gets taken off them, it gets stolen. And we've been able to provide their medication to them a few days or a week at a time. And people have been able to successfully complete treatment with that option provided. And of course, if people can't come to us, then we can take clinical services for hepatitis C to them with our outreach clinic. So we provide outreach health clinics in the Perth metro area and the Greater Southwest region. And we can do that with or without the use of our mobile clinic vans. We can provide these services directly to consumers at their homes, in open community spaces, or in collaboration with other services. And any ongoing follow-up is provided in the same flexible way. So what are the benefits of our approach? Patients certainly appreciate our approach and they come back. We have had people who have successfully completed treatment with us in the past who have become reinfected. And that may sound like a really negative thing, but the great thing about that is that people aren't waiting 5 to 10 years to come back. They come back straight away because they've discovered that they can access this service in a way that is respectful of their needs and respectful to them as individuals. There is no cost to use our services. It's easy to be seen. We can do outreach and testing at your home, and it's easy for patients to access treatment if they need it. So we're a one-stop shop. You won't have to go elsewhere to get your FibroScan or to have your bloods taken. We have peer workers who are trained to do that, or our nurse practitioner can help you with that here on site. So if you want to refer the people that you're working with to our health clinic, our clinics are walk-in, no appointment is necessary. However, we do always recommend that you would call us on the day before coming to make sure that a nurse or a peer worker is available to see you. Once again, this is a free service, and if you would like to contact our nurse practitioner, Leanne Myers, you can do that by emailing nurse@harmreductionwa.org. To inquire about our health clinic outreach, you may like to have that at your service. Our nurse and peer workers can come to your organisation to provide testing and follow-up. And to access that, you can contact our service manager, Neil Bodell, service.manager@harmreductionwa.org. Peer-based Harm Reduction WA can also provide training about hepatitis C for AOD workers. And this training is actually provided for free if you are accessing the WANADA HCV CAT program. You can learn or refresh your knowledge about Hep C, transmission, liver health, testing and treatment. The training is provided from a peer perspective with simple language, and it also provides tips about engaging with the people that you are working with about hepatitis C. And so lastly, peer-based harm reduction are here to help. You can call us anytime for consultation and advice about bloodborne viruses, safer injecting practices, safe disposal issues, and engaging effectively with your consumers. We can provide training tailored to your agency's specific needs and support with other issues as well. No question is too weird. Just give us a call and ask on 9325 8387. And lastly, here are some contacts on the screen. Just to reiterate what I've already said, if you'd like to access our clinic or inquire about our outreach clinic or access the Hep C training through the WANADA HCV CAT program. Thank you.
Hi, I'm Tabitha McCallum. I'm a consultant and auditor working for WANADA on the Hepatitis C capability building project. Hopefully now you're all inspired and keen to get on board with the AOD sector's push to eliminate Hep C. WANADA's role in this is both a commitment to supporting elimination of Hep C by 2030, but also as the AOD peak, supporting the sector through their contribution in capacity building and continuous quality improvement. That work's been going on since 2020 through a series of Hep C capability building projects which aim to support the sector to increase their HCV responsiveness, including referrals for testing and treatment. As part of this work, WANADA has developed a number of resources to support the services to measure and improve their capacity. The primary resource that's been developed is the Hepatitis C Virus Care Capability in AOD Treatment tool, which we call the HCV CAT. This tool came out of the first project WANADA undertook in this space in 2020, and it was based on the dual diagnosis capability and addiction tool, the DDCAT, which WANADA have subsequently also further developed and streamlined for use by AOD services. The tool, the HCV CAT tool, looks at 19 criteria organised into these 5 dimensions and measures a service's capability against each of the criteria. The HCV CAT is best used for review at a service or program level because across organisations, the HCV response could be different depending on their location, the program type, service delivery and structure, that kind of thing. So the services will take the CAT, work through the criteria, rating their capability, and importantly, looking to identify opportunities for improvement against that criteria. The tool's been tried and tested, and there's now a strong evidence base for its efficacy in increasing and sustaining HCV care capability in AOD services. Important to note, what we mean by HCV care in this context of the tool is the provision of information and education, screening for risk, and then referral for testing and treatment and ongoing support. So in 2021, WANADA piloted the tool in supported self-reviews with around a dozen metropolitan AOD services. The services did an initial pre-self-review, identifying and implementing opportunities for improvement, and then participated in a post-self-review to measure any subsequent changes in capability. The key to this process is really the identification of the opportunities for improvement, as well as measuring capability. So the tool guides services in areas they might like to consider for improvement. The results of the first rollout were really positive, with average capability ratings increasing between pre and post for all the services who participated. Following on from the initial positive indicators, and with new funding from the WA Department of Health, a new version of the project in 22-23 looked to roll the tool out further, with more services doing pre and post reviews. As with the first project, Peer-Based Harm Reduction WA came on board as a project partner with the provision of peer design and led Hep C training for staff for the AOD services who participated in self-reviews. The project also liaised with Hepatitis WA on resources and training opportunities. There was a strong focus as well on understanding barriers and enablers to doing the HCV-CAT self-review, and also barriers and enablers for AOD services in the provision of HCV care and support for their consumers. Service uptake of the tool and the self-reviews were great, and results from the project were overwhelmingly positive. So as with the first project, capability ratings continued to improve and be maintained. And this was particularly impressive. We did a third round of self-reviews with the organisation services who'd done pre and post in 2020. Their scores were particularly impressive because they had maintained their capability improvements even through the challenges presented by the pandemic. A really positive outcome of both rounds of the self-review projects was the identification of opportunities for improvement. So all the services identified a range of opportunities for improvement and had really good follow through in terms of implementing their opportunities for improvement. Similarly, in the 2022-23 project, we were able to identify those barriers and enablers that we'd been looking for example, collective challenges such as difficulty in accessing local and bulk billing GPs, and looking for other testing or treatment providers, and enablers like the value of increased staff confidence following the HCV training, the benefits of having HCV champions on staff, and using the tool to keep HCV on the agenda for the service. The sector participants also gave us really great feedback that year on the HCV-CAT tool itself and the self-reviews, and ways to develop it into a more sustainable process that could be used independently by the services and incorporated in the ongoing quality improvement processes. And that feedback was what underpinned the development of the new version of the tool in the 2024 project. So this is the new HCV-CAT that's come from the 2024 project. It's a more streamlined interactive PDF that will calculate your scores automatically when you use it electronically, but you can still print it out if you prefer to use for a hard copy. The dimensions have remained the same, as have most of the criteria. We've just removed some duplication, included one new criteria, and streamlined the order for ease of use. It includes now instructions on how to use the tool and how to run independent self-reviews with tips for making it a more effective process. So here's an example of the criteria from Dimension 1, which is culture and context. There are buttons you can click on which will provide you with more information, and a place for you to record your opportunities for improvement as you develop them. It's really important to consider these opportunities for improvement for each of the criteria as you work through. So you simply work through the criteria, the accompanying ratings, and click on the one you feel best represents your service. As you work your way through the tool, it will automatically record your ratings in this findings section at the end. It will also capture your opportunities for improvement, creating the beginnings of an action plan for you to implement those opportunities for improvement. As I mentioned earlier, there's appendices in the tool, useful suggestions about how to run a session, and lots of example opportunities for improvement to give you ideas. The HCV CAT tool is available on the WANADA website alongside a range of other accompanying resources. You can get there using this link or this QR code. So what's next? The AOD sector has such an important and valuable role to play in HCV elimination. So far in 2024, around 20 services have demonstrated their commitment to HCV elimination and quality improvement by conducting an independent self-review using the HCV CAT and making a commitment to embed that process in their continuous quality improvement. Many of those have also engaged with Peer-Based Harm Reduction WA, accessing their staff HepCB training. So jump on the website and download the HCV CAT. It's a great start. Work through the tool with your team and identify opportunities for improvement, and think about how you can embed this work into your service processes. Thanks for your time today. Please feel free to share this presentation. Go to the WANADA website, get started there on your HCV capability journey. Together we can eliminate Hep C by 2030.